Welcome everyone to our webinar, The Value of State Dementia Registries for Public Health Action for Dementia Caregiving. I'm going to give everyone a minute or so to get on and get settled, and we'll begin shortly. Thank you everyone, and thanks for joining us today. Thanks for joining us for our webinar today. We're going to be starting probably in the next 30 seconds or so. So thanks again, and we'll begin very, very soon. All right, welcome to the Bold Public Health Center of Excellence on Dementia Caregiving and our webinar today, The Value of State Dementia Registries for Public Health Action for Dementia Caregiving. Really appreciate your time and willingness to be here. I'll start with some opening comments, and then we'll have some very brief logistical slides, and then we're going to get right to it. You'll hear from this wonderful panel that have been kind enough to share their time and expertise in what it means to have a state dementia registry, its uses, and then perhaps as importantly, how do we move ahead and how do we go forward with this critically important work? And, you know, one of the reasons why we felt it was so critical to have a webinar on this topic and why we felt it fit into the scope of the BOLD, the Public Health Center of Excellence on Dementia Caregiving, is that I have found in engaging with many different audiences around the topic of dementia caregiving, whether it is with families themselves and people living with dementia, whether it's with legislators, community leaders, etc. I have always had some degree of frustration that the amount of more granular, localized information on not just the prevalence perhaps of dementia in a given community, but really what does that mean for that community in terms of how can we better tailor and target services and supports, facilitate policy development to meet the local needs of the people and organizations we work with. And granted, there have been great advances in developing national data sets, national resources to summarize not just the prevalence of dementia caregiving, but as importantly, the health ramifications of dementia and to some extent dementia caregiving. But to be blunt, while that resonates with some, it might not necessarily resonate with those who want to know, this is all great in terms of national averages, but how is this affecting this community? How is it affecting this county, this region? And that's why I think state registries are exciting development, and perhaps development that all states should be looking at seriously. Hence this topic today. And one last point is thinking perhaps beyond how some of these registries have been constructed at this point to really start to think about what has come up again and again as a key recommendation, both in the RAISE National Council report, as it has from the National Academies of Science, Engineering, and Medicine in their very pivotal report a few years ago on issues related to or the need to identify caregivers in a more systematic fashion so we can link them to people living with dementia and better understand the care context. So that is really the background for our registry today. Next slide, please. So I'm Joe Gogler. I direct the BOLD, building our largest dementia infrastructure, National Health Center of Excellence on dementia caregiving. Really, the objective of our center is to engage with, disseminate, and work with both state as well as local public health agencies to elevate dementia and dementia caregiving as matters of public health concern. And secondly, and as importantly, develop strategies, solutions, and evidence-based tools to really help advance, again, the public health importance of dementia caregiving. Next slide, please. We always begin our webinars with a land acknowledgement. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. Thank you. I've already alluded to this, but you see here what some of the not only the mission of the BOLD Public Health Center of Excellence on Dementia Caregiving, or PICO for short, is, but then also some of our key activities. One is improving access to the many, many evidence-based programs and practices that are now available to support dementia caregivers, and to think through and strategize how can these best and most effectively be disseminated through public health channels. Another key activity that we do, and you really see that today, is facilitating connections and collaborations with public health agencies and many, many other organizations in the space of dementia caregiving. And in this webinar series is one way we do that. And then we do provide technical assistance to public health agencies or even other organizations that, again, are looking to advance their work in dementia caregiving. Next slide, please. We are part of a larger collaborative called the Healthy Brain Initiative Collaborative. Again, this is hosted by the Centers for Disease Control and Prevention, which also kindly fund the PICOs, our center, as well as the two other national centers on dementia. You can see here the structure of the HBI Collaborative, and I encourage all of you to learn more about the collaborative, its members, and the resources we've assembled at hbicollaborative.org. Next slide. So we are going to be sending you a poll, and we hope you have time to answer it. But in what capacity are you attending this event? And if you take a second to please answer this, we would really appreciate it. So I'll give everyone a few seconds to answer. Looks like many of you are doing so. Thank you so much. Okay, I'm going to give you around 10 more seconds here, but many of you are answering. So again, we appreciate that. And excellent. Thank you, everyone, for doing that. And hopefully our team, Maya and Elma, are getting that information. We'll share the results here. Okay, I'm trying to share the results. It's not letting me. I'm just going to shut this down. But in any event, hopefully we have that information. Next slide, please. So I want to now turn to our panelists here. And again, we're so excited that so many of the states who have really led the way in developing dementia registries have done so. And I have some brief introductory descriptions of each of our esteemed panelists. And representing the state Alzheimer's disease and related dementia registries, we have Maggie Miller from South Carolina. Dr. Miller is the co-director and Alzheimer's disease registry manager for the Office for the Study of Aging in the Arnold School of Public Health at the University of South Carolina. She's also a research assistant professor in the Department of Epidemiology and Biostatistics at the University of South Carolina. Dr. Miller is currently a member of the Analysis Corps and Scientist Mentor for the Carolina Center for Alzheimer's Disease Minority Research, and serves as conference organizer and scientist mentor for the NIA-funded annual conference series entitled Promoting High-Impact Alzheimer's Disease Research Through the Use of Statewide Registries. We also have Rana Bayekli from Georgia. Rana is the chief epidemiologist and in chronic disease at the Georgia Department of Public Health. We also have with us Annie Rhodes from Virginia. Dr. Rhodes is a research scientist and director of the statewide Virginia Alzheimer's Disease Database at Virginia Commonwealth University's Virginia Center on Aging. She's also the director of applied research of long-term care and holds affiliate status with the Department of Gerontology, where she supervises the geriatric case management certification program. And then representing the public health perspective, we have Elizabeth Head from Georgia. Elizabeth is the Deputy Director of the Injury Prevention Program at the Georgia Department of Public Health. She coordinates the Be Seen project for Georgia, which is funded by the CDC BOLD program. The project aims to incorporate public health into dementia, including Alzheimer's work happening in the state. We also have Taylor Wilson from South Carolina. Taylor is the Director of Government Affairs at the Alzheimer's Association's South Carolina chapter. And then we have Dr. Katrina Taylor from California. Dr. Taylor is the Surveillance and Research Section Chief and Director Lead of the California Neurodegenerative Disease Registry and Parkinson's Disease Registry at the California Department of Public Health. In this role, she provides administrative guidance and leadership on planning, organizing, and directing activities that are compliant with statewide cancer and neurodegenerative disease surveillance data collection and health behavior surveys. Dr. Taylor is an expert in chronic disease surveillance, evaluation of evidence-based interventions, and use of health policies and data to inform healthcare delivery, data reporting, and policy implementation. Welcome to you all. We are so thrilled to have you here. And what we wanted to begin our conversation and webinar today was an introduction to state dementia registries and why they're important, and really also talking about this issue of collecting information, not just on the person with dementia, but the potentiality of doing so for family caregivers as well. So we're going to start with our registry panel. We're going to take around a half hour. And I have some questions here I'm going to direct to our panelists. For those of you in the audience, if you have questions that you would like to pose, please do use your Q&A button at the center bottom of your Zoom screen. So let's begin first with motivation. How was the registry launched in your respective states, and what was the motivation for it? And I'll start with Liz from Georgia.
Hi, thanks, Joe. Appreciate the time and seeing so many participants today. In Georgia, the Registry for Dementia and Alzheimer's Disease began around the same time as we were working on our state plan for dementia and Alzheimer's disease. That was 2013, 2014. We recognized a need to not only have a plan, but to have a way to collect data so that we would have a sense of the burden in our state. There's a huge and amazing partnership. There's a real depth and breadth of partnership in our state. And because we are a decentralized 159 county state, it's been really important for us to have a sense of where we are seeing the burden of disease. So having the registry in Georgia really went hand in hand with having a state plan so that we could do everything together. The Georgia legislature passed the law in 2014, and we receive $110,000 a year it helps with a person to manage the registry, and it helps with also receiving CMS data for those that have a dementia Alzheimer's diagnosis.
Wonderful. Thanks so much, Liz. I wonder if any of our other state participants would like to share a little bit of background from their own state registries. Perhaps Rana from Georgia, if you wanted to share.
I think Liz covered it.
Great, thank you so much. How about Annie or Maggie? Annie from Virginia, Maggie from South Carolina.
Sure, I can start. Thank you, everybody, for joining today. So in Virginia, we have, I think, the newest registry of all of the panelists. We sort of, I work at Virginia Commonwealth University in our Center on Aging and began collaborating with the Department of Health in Virginia in 2020 and officially launching our registry in 2021. And similar to what another panelist alluded to, we were really dissatisfied with the granularity of data available, especially for service providers in the state of Virginia, and knowing that Virginia is a state in the South that has a lot of health disparities and inequitable access to healthcare. We wanted to be really strategic about how we could be proactive in collecting information about folks with a diagnosis, folks at risk for a diagnosis, so preclinical Alzheimer's disease, and then their caregivers, and bring that under the umbrella of the Center on Aging and Department of Health. So it was really an idea of helping support the services that are already going on in Virginia with more of a data-driven approach, and merging those efforts with some advocacy to improve health equity across the state.
Wonderful. And Maggie from South Carolina, love to hear from you.
Yes, hello everybody. So South Carolina is the oldest statewide registry. And I was not part of the registry when it was created, because it was actually established back in 1988. And from what I know, it was developed by a visionary professor who was the chair of the Department of Epidemiology and Biostatistics here at USC. And they were doing a lot of research in the department, looking into health-related issues in our state, you know, us being in the stroke belt and everything. And just kept coming up. And this individual also had some experience with it in her family. So she was very well connected, able to connect with a lot of stakeholders, both clinical and within the university, and actually brought it to our legislator and got it signed in 1990. And at that time, we didn't really have very strong electronic medical record system. So they used graduate assistants to go into healthcare facilities, hospitals, even doctor's offices to abstract records and start collecting data that way. Now, over the years, of course, our systems have evolved, so we are a little bit different now. We access secondary data sources, but that's a little bit of our history and when we began.
Wonderful. Thank you all for sharing some background of each of your registries. And, you know, the next topic we wanted to talk about were those more in the ethical and legal space. And what are some legal and ethical concerns for making registry reporting of identifiable individual data mandatory? How does your registry address this balance between public health's need for individual data to assist in program planning, and then the confidentiality of personal data? This kind of relates to a question that was posed in the Q&A, which I thought was very interesting, is, are you having trouble, quote unquote, selling this idea to clients? It seems very stigmatizing to me. The only time I can think of needing to register in this way would be if you had AIDS or some other communicable disease. So with that in mind, Maggie, love to hear you address your thoughts on this key issue.
Yes, and this is a major issue, and I'm really interested to hear from the other registries about this. Our registry in South Carolina is a little bit unique. We are a voluntary registry, but as part of the legislation I mentioned previously, we're given permission to access secondary data sources. And our state has a data cube. It's actually housed in the Health and Demographics section of the Revenue and Fiscal Affairs Office. And they have a secure server that houses administrative data and insurance claims data. So what we do is we pull new cases that are identified through ICD-9 and ICD-10 codes through those data sources. And within that office, they have the identifying information. So they're able to link to the individuals, get a past history of diagnoses, and achieve other variables of interest. But then what is sent to us is a de-identified data set. But as part of that data set, each of our cases are given a unique identifier. And that's usually a part of their social security number, birth date, and that kind of thing. But we don't know what the number means. It's a unique unidentified number. But what's great about having that is that we can also go back and do additional research studies and link to the data sources to get more in-depth information. So we do not have identifying information. And most of the data requests that we do receive, we release the data in aggregate form. So it's usually count data, percentages, and that kind of thing, unless it is a formal research study. And in that case, the researcher has to fill out a detailed data request form, and that request is then reviewed by their data oversight council for each of the sources. So they have to give permission to release any sort of identifying data.
Thank you so much. Really appreciate that.
Mhm.
I don't know if any of the other states, Annie, perhaps at Virginia, if you wanted to talk a little bit about this.
I can speak a little bit about it because Virginia has a a component that makes it a little bit unique. So similar to what Dr. Miller spoke about, we have secondary access to data called the All Payer Claims Database. And here at Virginia Commonwealth University at the Center on Aging, I will never know, the identifiers of the folks who are in that registry. That is scraped and harmonized by our clinical and translational research center, and then given to me in a flat file, and any information or policy briefs that we would kind of provide to the public would be at a high level. So think zip code or census tract, because we are so conscious of the confidentiality, and we don't want folks to feel surveilled. Now, Virginia also has a pathway to services, because like I said, the goal of the registry is to correct disparities and take a data-driven approach to health equity. So we do have a self-enrollment arm where folks can click some links and actually enroll themselves. Now, our plan and our options, we provide as many options as possible. One of those options is to be completely de-identified. You don't have to give your name. You don't have to give where you live. You can just answer the Burfus questions about memory and caregiving for us. The other option is if you need help or you have stumbled upon our registry because you were actually looking for supports as a caregiver or as a person with a memory concern, we have established partnerships in our academic medical center to get you referrals to health services, to memory screening, to health coaching, to caregiver support. So we do try to offer levels of confidentiality or levels of service in order to kind of correct the imbalance that's existed for so long. It's a long and uphill battle, but I do think that by risk giving more than we're asking for, that starts to kind of correct the trust imbalances that have existed for so long, and then moving very, very carefully and very intentionally with input from the community at all times.
Thank you. We're going to move. Well, actually, I want to ask this question because I think this is utterly critical. It's critical for states like Minnesota, for example, if we ever did decide to do this. And I love to hear, say, for example, how Georgia addresses this.
Yeah.
Have your state registries supported the sovereignty of indigenous nations in your states in their right to govern and control access to data about their populations? Have you considered written agreements that specify who owns and can access these data? Relatedly, has your state considered the framework available for this and the care principles for indigenous data governance? I mean, a critical question. Would love to hear, Rana, your thoughts on this and more generally about confidentiality.
Yeah, thank you, Joe. So in Georgia, we do collect secondary data using hospital data, ER emergency room data. And we use the behavioral risk factor surveillance system. All these data are not identifiable, so they're de-identified. However, we do have a portal, and we do have data collected through electronic health record that we refer to HL7 messaging. These two data sets do include identifiable information such as patient name, date of birth, race, ethnicity, and it does have information on caregiver. However, our law does not allow us to share this information outside our wall. So our data are kept on a server. It's a very secure server, as well as restricted access. So only a couple of people who work with the registry have access to that identifiable information. Most of our data, we use the data that we get through the portal or through the electronic health record transfer to link it with other data set, but we do create a unique identifier using the identifiable information and link it with other data source. That way we can kind of respect and protect the privacy of the patient. The reason why we collect the caregiver information is because we needed to, based on our law, we are required to follow up with the caregiver to provide any additional information related to clinical trial or any services the caregiver could identify for their patient. At this point, we have not done any follow-up because of the fact that in reality, the medical record do miss information on caregiver information. So even though it is required by law, we do not have that data. In terms of working with indigenous population, Georgia does not have a recognized tribe. So we have not done any memorandum of understanding or data user agreement with indigenous population, but we do have the avenue if we are to collect data and the group decided that we need to have a memorandum of understanding to share data. We do have the standards and we do have the policies that we can do it. So that's kind of how we collect our data. In terms of presentation, we're similar to Virginia and South Carolina. We only produce data in an aggregate format, and we suppress any cells that have less than 5. We have been producing data to the county level and census tract level, but once we hit that 5, a number 5 patient or less, we suppress the data and we do not share it with the public.
Thank you. I would love any other states, particularly related to the indigenous sovereignty of data ownership question, if you have any insights to that. Okay. I think one thing that would be helpful for us, and if that attendee who lists themselves as anonymous in the Q&A, please follow up with us. I would very much like to know, again, there are other registries for other disease conditions. I know, for example, I believe there's a cancer registry and others, and maybe the second half of our presentation today can address this as well. But I would love to hear how these public health registries and these critical concerns for many tribes and indigenous communities are addressed as it relates to data ownership, because it's a critical question, and thank you for posing that. Let's move on to actually sustainability and funding, which is a key concern in any registry, as we all know. And the question we have here is, how is your particular registry funded? And what would be some key considerations for us to know to ensure the long-term sustainability of the registry? So Annie, I'll start with you. Maybe you could share with us how your registry was launched and is supported.
Sure. So we are, like I said, the new kid on the block, and we actually used BOLD funding to launch our registry with support from the Virginia Department of Health. And that was we have upped our BOLD funding now 3 times, and we also have university matching funds because the Virginia Center on Aging, while the registry is not codified, the Virginia Center on Aging does have a call from the state General Assembly to collect and maintain data on a statewide regional basis. And so the model of a registry does fit in very well with what we are already established to do. But sustainability is first thing on my mind, and why I think it's so important to get this particular ADRD registry codified.
Thank you very much. We do have a representative, actually someone who is critical in founding another state registry. This is the West Virginia registry, and Dr. Schroyers. Dr. Schroyers is actually in the audience, is not a panelist. But Dr. Schroyers, if you did want to add anything to any of these questions, we'll have Elma or Maya unmute you, and you can feel free to contribute. But in the meantime, let's move on here. And did Dr. Schroyer's, this is kind of hard to manage here. So let's move on to
Joe, he can,
Okay.
Dr. Schroers can talk right now.
Okay, great.
unmuted
Dr.
him.
Schroyers, thanks for joining us. Can you please, I don't know if you wanted to address any of these questions.
Thank you very much. Yes, this is Bernie Schroers. I'm the director of the West Virginia Alzheimer's Disease Registry. We're the second oldest, and we took a lot of wonderful information from the South Carolina registry when we first started our registry, which is instantiated in state law. We actually had a line item in the state budget for many years, but because of contraction in the state budget, we are no longer funded, which is causing us considerable difficulty because we also extract secondary data, particularly from Medicare. And although we're state mandated, Medicare data are still need to be purchased. And so we're sometimes having issues trying to collect those data. And so the registry is actually experiencing some difficulties as a result of those budget restrictions. Thank you.
Wonderful. Again, thanks for joining us here today and providing that the insights from West Virginia as well. Georgia, I don't know, Liz, Rana, anyone from Georgia wanted to talk a little bit about the funding for your particular state registry. It's interesting hearing how all of these are more or less funded by different models, and I'd love to hear about Georgia's.
Yeah, I can describe how we're funded. So in Georgia, it's a legislative line item. We do receive $110,000 each year, and we have been receiving it since 2014. What we use this funding is actually to support a staff at the Georgia Department of Public Health and epidemiologists, as well as to purchase our Medicare data, like Bernie mentioned earlier. However, we do partner. We have a lot of partners that support data collection. So, for instance, we have partnered with the Division of Aging, who are highly interested in ADRD registry to collect information, cognitive impairment, and the caregiver module on the behavioral risk factor surveillance system. So we have created a mechanism for the Division of Aging to support these two modules in an alternative year. We also, since we are in the Division of in Public Health, we have partnered with our Office of Health Indicators for Planning to receive regularly the data from hospital discharge data, emergency room data, and partner with our vital record to receive data on death related to Alzheimer and other related dementia. So that data, we do not pay for it. And since we are part of public health, we have access to it directly. The other thing is this money that we receive has been very useful, the $110,000, because we actually use this funding to maintain the BOLD funding, or to provide it as a maintenance or match funding to receive the BOLD money to Georgia. And for sustainability, I think we have been using the data, we have been sharing the data with various partners, and the hope is the partners continue to find a meaningful use of the data and support the various initiatives with the data. Recently, we have worked with this office and with the Division of Aging of creating formula of estimating patients, Alzheimer patients, throughout the various part of Georgia in the 159 counties. And the idea is to use that information to help them in future planning. So the more we do, in my opinion, the more we make the data usable, the more we make the data practical. The hope is money that people will, or partners will see how important data are and will support us when we ask for funding. I agree with Bernie. We have stretched our 110,000 to the max. And in order for us to maintain and expand, we really need more funding, and the funding would be used for really supporting more management type positions. We're restricted because of this 110, we're restricted in what the hospitals that we are working with. So we are technically now working only with what we call the Georgia Memory Net, because they're funded separately, and they do a lot of training for their hospitals and receiving data from these hospitals, at least giving us a standard and high quality data. So at this point, we reduce that management piece because we're only using data coming from high quality providers.
Thank you so much. I wanted to go to a question posed in the Q&A. This is from Christina Bloomquist. Thank you for joining us here, Christina. And do each of the registries use a common data model to structure their data? What is that model used, and is it the same across all state registries, for example, OMOP? And I'm actually going to direct this to you, Dr. Miller. I'd love to hear your answer, and then we'll hear from the other states.
Yes, I think in a perfect world, we would have a standardized reporting system. Currently, we do not. We all pull from various different data sources, and so it really depends on what data is available. I think we all actually published a paper recently that compared the established ADRD registries to cancer registries, and really promoted and discussed how it's important to have a more standardized system. But without standardized access to different various data sources, it's really, really difficult to do. So at this point in time, we do not, and we all collect different types of data.
Thank you. And did any of the other states want to address that? Maybe Dr. Schreiers, West Virginia?
We do not have a standard model at the moment. We aggregate data from Medicare files. We have physicians who report directly to a web portal, and we store data on a encrypted, protected server. And as Maggie said, Dr. Miller said, because we're all collecting from slightly different types of data and data sources, we haven't synchronized or harmonized our registries because we are so disparate, and I think that's a weakness, actually, and something that we will probably revisit, because we are talking to each other quite regularly, including the paper we just published that Dr. Miller spoke about, and we have conferences where we think about these things. But I don't want people to lose sight of the fact, and I think the other registries can speak to this, about the impact that the registries have currently. And Joe, I don't want to presume, but if that's something that you were thinking about talking about later, I'd love to contribute.
I think we should talk about it now. And what I'd like to do as we kind of move towards the last few minutes of this part of the discussion is talk about what you've seen in terms of impact of your registries, and also to think about how can caregivers potentially be included in a registry model. We know for a lot of reasons that that's hard to do at this point, but I'd like to hear from you all. Where do you think caregiving fits into this registry model, if it can ever be incorporated, and what your ideas are?
I'd like to give two examples of the impact that the West Virginia Alzheimer's Disease Registry has had locally, and it includes an impact on caregivers. The first is some interesting work that we did to accumulate data from Medicare data files at the county level. And then working very closely with the Alzheimer's Association West Virginia chapter and their volunteers, take those data at the legislators level. So these folks got data from an individual electoral district and went to those electors and said, this is how many people in your county, in your electoral district, have a diagnosis of Alzheimer's disease. And as a result of that, two things happened. The first was that the Alzheimer's Association, together with our data, were able to convince legislators that they needed to have first responders and particularly the police trained in dealing with people who have dementia. Because as you know, if we have someone who's lost, someone who's wandering around, and maybe behaving a little strangely, the police are in a mode that may not be conducive to helping these people get back to where they belong. So that was the first thing. And the second thing was we were also able to convince legislators that it was important for medical providers to have more training in dementia assessment and treatment. And so legislation was passed this year that encouraged the public health department to increase their training of healthcare providers in dementia assessment and treatment. So they were two things that I think we were able to contribute in our own small way by taking data that we had as well as publicly available data at the county level. And because West Virginia is a small state where a lot of people know each other, we were able to get those things through the legislator, and they do have a day-to-day impact. Thank you.
Wonderful. Other examples, and again, thinking about the caregiving dimension.
So we, in Georgia, we did something similar to what Bernie just said, is really providing the data to the county level as much as possible. And, you know, in terms of our partners, the Injury Prevention or BOLD, have taken that data and have done some assessment in some counties and really get more participation by public health at the public health clinic. And I'm hoping that Liz can speak more about the initiative of getting more screenings and getting the screenings more into getting people more into care. So in terms of caregiver, what we have done is, for using the behavioral risk factor surveillance, we have talked a lot about who are the caregiver, how are they related to the patient that they're taking care of, and the health conditions that they are in. And with the GUARD, that is our collaborative community, they have done a lot of reach to caregiver, providing them services in terms of educational support, in terms of things that they would need to support their patients. So that's kind of how we, in terms of the registry, help support the caregivers in taking care of in the dementia patients.
Maybe we can hear shortly. I don't mean to cut you off, Rana. I want to move to the second part of the panel, but briefly from the other states considering this question and addressing. I don't know if South Carolina or Virginia have any thoughts.
Yeah, I can give you just a brief update. Sorry, Annie, didn't mean to cut you off.
No, you go. You're great.
Okay, so in South Carolina, we also used our data and we broke it down to county level and then also zip code level data and shared that information with legislators as well. And we were able to look at over time increase in cases in some of these counties. I mean, we would see, 500, 600% increase. So I think these kind of fact sheets and this information truly hits home when you can really see the changes that happen over time. We've also shared this data with our Department on Aging, and they have been able to identify areas of need that need, respite, adult daycare centers, and also other support services that are lacking. So we can see there's this number of cases and really very few services. So I feel like this kind of data has a very, very big impact on caregivers and where their needs really lie.
Yeah, it's interesting. And Annie, please.
Sure. Well, our project has a self-enroll arm for caregivers where not only can they put themselves in, but they can also get help if they would like it. And so we developed partnerships prior to launching with other components of our academic medical center and to directly connect those caregivers. So when folks, if they need help, they can get it.
Yeah.
And then on top of that, I think being a statewide coordinating sort of center for data, we're able to convene with the Department of Health and our Department of Aging to talk about messaging, to talk about data coordination and data stewardship. And so all of those things have an impact. And then from like a data logistics side, we also do scrape and control for CPT codes. So we can tell if services were provided in a memory care.
Annie, out of curiosity, do you know, so it sounds like caregivers can self-report or self-enroll into the registry. Do you know what percent of people with dementia in your registry have had a caregiver self-enroll?
So I did have this up yesterday. We have like 30%.
That's not bad. I mean,
No,
it's
not at all.
Mm.
Not at all. And it will only continue to grow as we develop those partnerships.
Yeah.
Yeah.
I mean, we're going to move on to the next part. This has been wonderful, all of you. One thing I would encourage our panelists to do is there are several questions in the Q&A that are open that we haven't had a chance to get to at least yet. Feel free to type in your answers directly to some of those if you feel that you can answer them. I think what's interesting is when we think of the caregiving piece here, which we have to do as part of our center, is right now the answers have been in terms of a caregiving component to the registry, either the self-enrollment option or really making the case that by having, again, localized granular data on dementia prevalence, need, et cetera, that by extension can help caregivers by targeting services and supports, which I think is interesting. But still, the question of can we ever get to the point where we can identify caregivers within existing secondary data sources, claims, whatever. And we're still not at that point from my impression, but nonetheless, thank you all. This has been wonderful. And thank you for your efforts in being national leaders in this. I think many of our states can learn a great deal from you, and we're happy to support you in any way we can. Thank you, everybody. Thank you for this first group of panelists. We're now going to turn to the public health perspective. Again, we have Liz Head from Georgia, Taylor Wilson from South Carolina, and Dr. Katrina Taylor from California with us here. And would like to start directing some questions to them if they're ready. And, the first question I have is what are current sources of caregiving data that you use as public health experts? And based on what you learned today, how do you envision a state dementia registry can complement some of these other sources? And would love to start with you, Dr. Taylor, and to hear the California perspective.
So for California, we use behavioral risk factor surveillance survey currently to select cognitive decline and also caregiver modules. But to really think about how we can expand that out, and I really, really loved, I want to say it was maybe what either Anna or Rana may have said about linking that data and also the registry data back to some of the hospitalization data and also some of the mortality data. So really for us, in particular in California, it's really about identifying the case definition for Alzheimer's. We did have legislation that was passed in our state for us to be able to collect Alzheimer's disease. However, we're still in the process of trying to define what Alzheimer's is and how we can look at that, because it was not included with dementia. So we have to really be clear on what does Alzheimer's mean. So like for other states who already have these conditions in their registries, it's very important for us to understand how they separated out what was Alzheimer's disease from an ICD-10 perspective in defining that, and also the dementias, because what we're afraid of is that as we start start to develop out our registry, that we'll get pushback from the providers with saying, well, you guys are asking for more than what you are legislatively mandated to collect. However, there is some ambiguousness in the legislation itself that may allow us later to ask for dementia-related information, but to really just inform those pieces. So ideally, like for the initial question, it's really, we use the behavioral risk factor surveillance survey to collect that cognitive decline and caregiver module. And we use it in the same way as other states to really understand where there are gaps in care and services and where those services are needed.
Thank you so much, Katrina. Very much appreciate that and all the great work California does in this space. Liz, from Georgia's perspective, I don't know if you wanted to address this as well.
Yeah, happy to. I absolutely agree with what Dr. Taylor said. BRFIS is by far our primary source for caregiver data. We also do the caregiver module in even years in Georgia and the perceived cognitive impairment module in odd years. But really, you know, when we're looking at burden of disease, we have to assume that where there are diagnoses of dementia and Alzheimer's disease, there are caregivers. And so one of the approaches that we're taking is the Georgia legislature just made an investment related to dementia care specialists. Those dollars go to the State Unit on Aging, and there'll be one dementia care specialist in each of our AAAs in our state. Specifically, those folks are charged with gathering the resources, bringing the people together. There's an emphasis on care partners and providing resources for care partners there, making sure that everyone that is there that could be a care partner knows about and has the potential to access the locally available resources. So that's just getting started in our state, but we do anticipate that being a great source of potential data for, you know, what is, you know, how many caregivers are there in a given area? You know, maybe oftentimes we know that family members, there's multiple family members caring for the same person, right? So they are all going to have their individual needs. So we hope to get at that, but at this time, BRFIS is still our primary source of data.
Yeah, and this might be a question, maybe we'll kick this to the Q&A session in general. You know, one of the things I wonder about, and maybe the registries do address this, and I think they might, is, you know, one of the things with BRFIS is, again, it's one of our few resources we have likely for our own respective states to get information on dementia caregiving, maybe even prevalence and such. But it's also a snapshot. I mean, you're not following individuals over time to actually see trends or changes. And I think the registries address that to some extent, unless I'm wrong. For example, does the Georgia registry, you have individuals in the registry, can you track individuals and see change over time? And then why I think that's important, for example, is, you know, to evaluate, say, policies or programmatic developments or changes alongside these changes in key health outcomes. Again, I don't want to redirect our conversation here, but something to think about. Maybe we'll turn that back to that in the Q&A, particularly for the first part of our panel. I don't know, Taylor, did you want to add anything to this from the Alzheimer's Association perspective in South Carolina?
I think the only thing that I mentioned is that it's interesting because I know all of the Alzheimer's Association directors of government affairs in all of these states that are talking, and you're talking about what got passed and when. And so the first thing that I would recommend if you're looking into getting a registry started is to contact the Alzheimer's Association, because we copy and paste off each other all the time. We can get that statute language, we can get the budgetary language for you.
Yeah.
We can help walk that through. So that's your first step, really. So that's just my plug for that, because everything that you guys are talking about, we're working on at a different point. I'm working on dementia care specialists next year. So, you know, it's all connected.
Wonderful. Thank you, Taylor. That's great. Appreciate that. So let's move on to the next question here, which are data gaps and what's missing. What do you all feel is missing and would be ideal to have in furthering your own respective work in your states and through your public health agencies? Dr. Taylor, what do you think?
So I think for us, it might be initially just collaboration for definitions. So we don't want to create a burden for any organization or health system that is providing the data. So really identifying like what is the easiest way to get buy-in from the providers to share data. So
Oh,
for us, like that's step number one. And then progressively collect the data to show that there's value in the data that's being collected to providers and then also to our constituents so that they understand like we need support and supporting public health departments with data collection. And then also looking at like the equity components. Like if we have the data, then what are the next steps? So our job is always to educate. So we want to be able to use that data to educate, so to make sure that we have the support to collect those components so where we can get out like where there are disparities, where there are gaps in services, where there are inequities in screening, potentially like gaps in data reporting.
thank you so much. Taylor, how would you answer that question?
So coming from the aspect of, I know there's a lot of people here who are way smarter than me and are doing public health. And then there's also researchers on here, but from a public policy standpoint, I think that you also have to talk about money. And how does a dementia diagnosis, dementia prevalence, dementia hotspot in our community hurt capital and also increase opportunities for economic development? And so that's something that I'm starting to look at right now is number one, where are we costing the most? There's repeated hospitalizations, comorbidities, things of that nature. How do we use those to overlay to make a case for we need to spend now in risk reduction and early detection, early diagnosis to improve outcomes for the person with mild cognitive impairment or early stage dementia and their families? But at the flip side, where are we lacking in infrastructure where we could work with chambers of commerce to incentivize things like adult day, things like home and community-based services? What we're recognizing now is that when we give out our respite funding in South Carolina, even though it's based on prevalence, we get money back every year.
Oh,
The caregivers can't spend it. And it's because there are no services.
they're not
So
available, right?
Right. So when we're looking at this, we're putting the cart before the horse. I don't need to go in and ask for more respite dollars. I need to go and talk to South Carolina Chamber of Commerce and talk about how we incentivize home and community-based services and, adult day centers. So that's where we start to talk about policy strategy being informed by data. And it really does have to have these conversations around financial impact. And so when we're talking about data registries, we really can show hotspots and then overlay the money and the cost and say, do you see where we're lacking the infrastructure to be able, it's costing more money, we need to do something
Yeah,
about it.
I am by no means a policy guru, so take this with a grain of salt, but when I think about exactly what you're talking about, Taylor, I mean, oftentimes we think of engagement and partnerships maybe with the healthcare system or something like that, but you mentioned chambers of commerce and maybe there are ways to leverage these types of data to show employers in a certain community, many of whom are looking for employees and making the case that if you have a high prevalence of dementia, chances are, and this is where direct caregiving may be very helpful, chances are you might have many people in that community who otherwise would be working but can't because they're in caregiving. What can we do to help facilitate that? You know what I'm saying? Those kinds of policy strategies, I would imagine could help, particularly given some of the states. Go ahead, what?
We were able to angle support groups into
Yeah.
companies because they were caregivers.
Right.
And we started to work on stress reduction and they
Yeah.
started to have more frequency of showing up to work because they weren't as run down. And that wasn't something that we, at the beginning.
Yeah, so you made the case, but was care support infrastructure built in response to that?
Yes.
Yes,
So
that's what's
that-
important, right?
Yeah,
Okay.
so that's what I'm saying is that data can help the strategy in some for-profit communities as well. A lot of times dementia gets relegated into a healthcare issue or a neurological issue but it is a hammer to glass. When it impacts a family, it shatters everything. It shatters a tax system, it shatters the healthcare system, it shatters the family. We've got to start looking at a 360 model to really start making an impact. And so it also brings a lot of people to the table that you wouldn't expect who are willing to fund innovative initiatives like pilot programs with dementia registries. So those are all just to say that it can help inform strategy if you talk about money with it. So that's been something that's been helpful for us.
Wonderful, thank you. Liz, I don't know if you wanted to add to this?
Yeah, I certainly agree with my co-panelists' comments. We want more. We're we're missing more data is the, sort of flippant obvious answer. But with that, specifically looking into those with mild cognitive impairment, the younger years, really emphasizing brain health and establishing dementias as a set of brain diseases so that folks want to normalize finding out if their brain is as healthy as their colon, getting these screenings, getting them in, getting them tracked so we have a better sense of how we can get things in place sooner so that we can help these folks have a better quality of life as they're going. And the only way to do that is with data about brain health and normalizing that and getting these screenings in a lot sooner.
What do you think? This is my own question again. I guess I have some pride to ask these, but what do you think about the data that are collected in terms of usefulness to advocate for policy and funding and such? I mean, you heard a little bit, Taylor, and you heard Taylor bring up the example that we just had a conversation about data that you can use and bring to, say, a chamber of commerce to help make an informed decision and perhaps funding. And do we actually have a good grasp of what are the data elements that matter, first and foremost, to people living with dementia and their caregivers, of course, but then to some of these other entities that are making decisions, like a healthcare system, a health plan, others that could be motivated to maybe expand support and services. I don't expect you to answer this necessarily, but to me, that's a driving question as well. Not only we think of registry data, but I think in all of our data that we collect. I think for too long, we collect data elements that maybe don't have a lot of relevance to people.
I think we have to connect some of the dots. So when we think of folks managing 4 and more chronic conditions, those folks are where we need to be talking about brain health. And we have that data. We have that. We have a lot of that data. So utilizing that data and layering it in such a way that we are able to talk about it as easily as we talk about fall prevention. Folks want to know how they cannot fall, right? Folks have no desire to talk about taking away their car keys. They have no desire to talk anything about a loss of brain function, which impacts every other thing about independence, your ability to contribute financially to your family, your ability to be a productive member of society. So backing out, which seems counterproductive for a second, and talking more about the things that we are able to talk about, but infusing brain health is a place to start with that.
Thank
and
you.
I like that Liz brought that up about confidentiality and reporting of neuro conditions, and especially of Alzheimer's, because it is that loss of freedom that people are fearful of. And if the registry is a caveat to add value to public health through the research that's being conducted based on the data that we collect, then there has to be some level of confidentiality, or even just knowing that by being included in a registry, you're not going to automatically be reported to the DMV. So that's a whole nother section that has absolutely nothing to do with the registry. So the messaging piece may be very important when connecting those dots about how the data will be used and how it's being used for research to really inform public health and public health practice.
Yeah. And all of this lends itself to this larger and so critical conversation about equity. Until we normalize this as a conversation and as a piece of our regular health, we're going to really still struggle with all aspects of equity because we haven't normalized it in any population. Certainly not in the folks that are at the highest risk and bear the brunt of the burden of this set of diseases. So we have to keep, I always used to talk in traffic safety about remember evaluation. We have to remember equity, just like we have to remember evaluation at the beginning and not toss it in as a buzzword later on.
Oh my God, Liz, you are bringing in all the really important pieces. That is so important because equity, people tend to think about it just as race. And it's not. It's about how resources are allocated, and especially within healthcare. Standard of care is not, it is standard, yes, but you have to go above and beyond for certain groups. And that's where that screening becomes very vital. And then you have those precursors from the medical history, from the family history, from the actual screening that happens for you to determine the next level of care to give. And that's the equity piece that people tend to disconnect from what equitable services are. So excellent. Thank
So
you.
let's, I mean, I think that's a critical point, and let's maybe talk more about that as time permits, which is what can we do to ensure representation for these communities, if not in building a registry, but beyond? I mean, what are the strategies to ensure that if one builds a registry that is indeed equitable? And how should that be done? I'd like to hear from our panelists on that regard.
Engagement, not just outreach. I'm never going to say don't do outreach. That would be terrible, right? But it's engagement, not outreach. I cannot come, so, and this is a very specific Georgia example, I cannot come into South Georgia from the state of Atlanta with my cape on, ready to save the world. It has got to be on the ground in those rural communities, hearing them, listening to them, not talking. Let them dictate what they need. They know what they need. They know how they want to receive it. They know who needs it and how to get to them. We have to listen in that way. And I'm really, one of the things I'm most proud of in Georgia is the rural outreach that our friends at the University of Georgia are doing. They're creating collaboratives around this where they, you know, just facilitate a little bit. And then the community coalesces around that idea, and they're building in some sustainability. And now we have our friends at the State Unit on Aging coming in, recognizing that those new dementia care specialists need collaboratives, and they're not creating new ones. They are asking to join the already established local collaboratives that UGA is working on. So now we've got state agencies and academic partners and community-based organizations actually talking about what they can provide based on the recommendations of the community, not just based on what the data tells us. We got into that community. We went to that community because of what the data told us.
Very interesting.
But
Yeah,
then we
it's an
stopped.
interesting perspective. Very,
Right.
yes. Others, I'd like to hear what others have to say.
I think it's also important to remember that you need to report the data back to the community that you get it from. And that is something that I think we forget, because we need to make sure that it's simple and clear enough that the community understands what their input showed. Because while they can witness it, they may not be as conscious of it as they would like to be of what's actually occurring in their community. And so giving that data back to them in a way that is clear for them to be able to digest may actually engender more support in that community, specifically with community leaders and change makers. So don't forget about that returning that data once it has been collected and collated back to the community, because that really does help us with how we move forward in community change. You know, I talk all the time about South Carolina is an 80% rural state. If you don't know the dialect from west to east as you move up 95, they're going to call you out. They're going to know that you don't know who you're talking to, the group that you're talking to. So it's just like Georgia, just like some of these other places. But the one thing that is consistent is compassion. Showing compassion for that community, for their caregivers, and that you are there to help is key. It's just not measurable. So show them what compassion looks like by going back to them and respecting them enough to share with them what you found before you start asking for more from them, I think is always key.
Dr. Taylor, please.
I mean, they have summed it up perfectly. I mean, you definitely, you don't want to do that circular conversation where, you know, we have the data so we know why we're there, but then we want to dictate to the community as to why we're there, but to really do the listening and then return back to the community how we triangulated the data from what they said to what we found out for the reason that we were there, and then also the recommendations that we have. I mean, I think Liz and Taylor hit it spot on.
Yeah. You know, it's interesting when we think of, and you know, some of the ways we've positioned this conversation have been using data to find gaps and then getting services to address gaps. But, you know, if we approach this from a more humble perspective, like Liz and Taylor and Dr. Taylor have been mentioning, you know, it could very well be these communities are addressing these issues in ways we just don't know about, and in very innovative ways, in fact. So maybe flipping this perspective away from one of a need and one about strength, and what do these communities actually bring, and how can we learn from them? in that regard, and having this kind of engagement model like Liz talked about. I think that's really interesting. So let's move on, and we have several other questions, and then we're going to open it up to Q&A from the audience itself here. But in the end here, what are lessons learned or strategies you would recommend to other public health departments interested in establishing a registry? Those of you that are familiar in your states with registries or not, what would be the main recommendations you would leave the audience here?
A lot
So
of
I,
time. Oh, go ahead, Taylor.
so I think that the first key component is awareness of the registry. You need to make sure that you have a model for sharing with others about how that you are developing a registry, that you have a registry, and then that they can use that data, because we can collect data all day long, but until we use it to inform policy, until we use it to inform programs, until we use it to overlay, to identify severe need, it's just numbers. And I know that there's epidemiologists who just cringed when I said that, but data only functions if it makes change. And so I think, or it educates. And so it's awareness. Get your coalition together and make sure you have the change makers that you want on it if you're just starting a registry. And if you have a registry, shout about it loud and clear. Maggie, I always tell her, I'm like, listen, I'm going to do another press conference and talk about the registry. And Maggie's just like, okay, like you can't stop me from speaking about it because it's important, because I want other people to go, well, how do I get access to this? And while I'm sitting here, I literally had a senator just call me and said, hey, I've got an event on Saturday. Can you send me all of my fact sheets? So that's how we know we're getting through to these folks.
Yeah,
those just voted. You just voted on a state plan and $10 million in research, Alzheimer's research budget.
Yeah, that's great.
So that's what we're looking for. So awareness.
Yeah, great point. What do others think?
So then I would also say the collaboration. So make sure that you have like those technical advisory groups. I'm not going to say like an advisory council, because ideally we know like what like the logistics are behind the registry, but really making sure that the case definitions are clear, the burden, or just I don't want to call it burden, but maybe like awareness for the providers on why they're providing that data, so that we can show value in the registry itself. And then making sure that we connect with like those rural areas. So then if you are developing a registry that either uses electronic medical records, and those organizations or those health systems do not have that, to make sure that there's a mechanism to collect the data that does not cause more delay in the receiving of the data. Because then, almost like what Taylor said, the numbers, if you get the data and you can't really tell a story about it, it doesn't matter. But then if you don't have enough data to tell the story, then it also tells a biased story. So just make sure that there is, like she said, education and awareness out there that there's a registry happening. Make sure you have the right players at the table so that we're collecting the right information to inform health outcomes.
Wonderful. Liz, I'll leave you with the last word here.
Yeah, thanks. We really started with educating our existing partners. So all the people that are on and participate in either our work groups for our state collaborative for dementia and Alzheimer's, we educated them on our baseline data, hospitalizations, deaths, and ER visits in that public facing website, the population counts that are available on our DPH Oasis website, showing them how to use that data, how to find that data. And then they started asking questions, which is beautiful because they want to know, right? And so then we can transition into conversation into the BRFIS data and getting that eventually up onto our website so that they can use that and teaching them how to use it. That is the most basic thing. And then as Taylor and Dr. Taylor said, just shouting it from the rooftops. You've got to keep talking about the availability, how to use it, and where to use it.
Thank you, everyone. Well, this has been just a great conversation here. And in our remaining 15 minutes, I would like to open this up to question and answer. And we have quite a few in the Q&A box that I'm going to start asking, really to all of our panelists here today, those that represented the public health perspective, and then those that presented on this specific state registries here earlier. So in looking through some here, this was for you. Actually, I think I saw a question, Liz, directed to you. You might have answered it all. It had to do with the utility of the cognitive module. That might have been answered already. So let's do this. For those of you in the audience, have there been any efforts in your state to implement a registry that you are aware of? And if so, how has that gone? What have been some challenges, issues, et cetera? You can certainly feel free to raise your hand if you want to talk. You can submit something in chat as well, but we can certainly start with that. I'd love to hear from the state level what is going on locally in terms of registries, if that's even of interest. So. Otherwise, panelists, if you happen to have questions of each other, please feel free to ask them as well.
Okay, so,
yeah,
so I
please.
do have one question, and it goes back to my initial statement when I first started on this panel. How did you all differentiate between Alzheimer's and dementia in the coding?
In West Virginia, we haven't. I think the truth of the matter is that dementia is an umbrella term, but 60 to 70% of all dementias tend to be Alzheimer's disease. And because we have problems with a differential diagnosis, when we see cognitive impairment, it's sometimes, I mean, the gold standard used to be an autopsy diagnosis of Alzheimer's disease. We typically say it's probable Alzheimer's disease. Now with some imaging modalities, that has changed a little bit, but even if you're imaging for beta amyloid plaques, we know that there are lots of people walking around with lots of beta amyloid in their brain who really aren't cognitively impaired, and the reverse is also true. So it's not, again, differentially diagnosis, and that's one of the problems we have in this field, is that difficulty in making the diagnosis in the first place.
Thank you for that. In looking at the Q&A box here, this is from Carrie Sharon. I think this is a really interesting question. Do any of your states have dementia-friendly initiatives? And if so, do you work with them?
Yeah, absolutely. Actually, one of our work groups within the Collaborative for Dementia and Alzheimer's disease in our state, they focus in specifically on dementia friendly. Our state unit on aging has been focused on it. One of the commitments from our public health leadership at my agency has now decided that he wants to champion dementia friendly counties, as DeKalb County in Georgia has just declared themselves within the last 6 or 8 months, an entire dementia friendly community. So that just really opens the door for conversation. It means they've put in some work and their businesses are on board and their nonprofits are on board. So working with those folks is really a joy, because they've already done the hard part of knocking on the door and saying, hey, here we are.
That's great. So again, in the Q&A box, I see Montana has just applied for a BOLD grant. So this is important information. That's great to see. Again, for those of you states there, I would love to hear from you as far as where you are at in developing state registries. I can speak from the Minnesota perspective to some extent, although it's been a few years. We had a very large convening of all the major entities and offices, including people living with dementia and caregivers back, I want to say it was 2018 or 19. And that ended up turning into our main updated state plan on Alzheimer's. And I chaired, if I recall, I chaired kind of the surveillance and epidemiology. And one of the recommendations was to, if not start a registry, find ways to integrate other sources of information to better track prevalence information and such. And I'm not sure how far we've gotten on that as a state to this point. But it's something certainly that we are hoping to move forward on. Now, Rana, please, you have your hand up.
Joe, I just wanted to make a comment related to indigenous population and other registries, how data are handled or reported. Because I do work with the cancer registry, and that registry is a complete registry, and there's a lot of assessment on data completeness, which we hope at some point we can duplicate for the ADRD registry. But in the cancer registry, what we have done, because we receive funding from CDC, CDC has done a memorandum of understanding with Indian Health Service office. And what we do, we submit data on an annual basis to IHS. They link the data for us, and IHS provide us with that race category for Native American population. So we then populate our data with the right racial category. It has been a huge improvement in identifying Native American population in the cancer registry for those states that do not have organized tribes, like the state of Georgia. I don't want people to misunderstand saying that we do not have indigenous population in Georgia. It's that we do not have an organized tribe where we have a rosters that we can link against. I just wanted to clarify that, and there were a couple of questions related to this, and I wanted to make sure that I cover it appropriately. Thank you.
Thank you, Rana. That very important clarification. Appreciate that. We'll go to Taylor, and then we actually have someone from the audience who raised their hand. But Taylor, please.
I actually wanted to bring up in terms of ways that you can start to utilize different stakeholders is something that I'm working with. Is I've accumulated almost a subcommittee of researchers and epidemiologists that serve on our Alzheimer's Resource Coordination Council and Advisory Council at the state level. We're creating a wish list of data that we would like to see overlaid on top of prevalence data, so that we can continue to look for data sources that would match up to allow us to do a comparison, to make the case for different things that caregivers and families facing dementia need. So I recommend getting a group together of some of your best epidemiologists from your state agencies, your state agency on public health, aging unit, all of those, and really start to keep a wish list of data. And you can kind of tick those off as we get that data source and utilize it for its functions. So that's just part of my lessons learned, things that we're attempting in South Carolina, but something that we're really excited about.
Great. Thank you, Taylor, so much for that. Appreciate it. So we have someone from the audience raise their hand, Angela Allen. I'm going to allow you to talk vis-a-vis Zoom, of course, Angela. And feel free to, ask your question or what you were going to share.
Thank you so much. Angela Allen from Banner Alzheimer's Institute. I am here, in Phoenix, Arizona. And a couple of statements I will make. One, we do have a huge dementia-friendly program out here. We've actually tapped into about 8 different cities. Phoenix, of course, is one, Tucson, Surprise, and various others, in which we've created the dementia-friendly programs. Currently, I'm working within the inpatient clinical setting, creating a dementia-friendly culture within inpatient settings, which I believe that's one of the greatest concerns, because the bedside healthcare providers may not know as much. The other thing is we do have a registry, various registries, but the one that you may be very familiar with is called Alzheimer's Preventive Initiative, which was actually established in the area of Alzheimer's prevention research. And we actually partner, Banner Alzheimer's and Banner Sun Health Research Institute, partners with academia, industry, and other public and private stakeholders. It's an NIA program, and basically the whole plan is to actually look at prevention therapy by 2025. And then the last two I'll emphasize on is Us Against Alzheimer's. We utilize, well, myself in particular with the research that I do within the clinical setting, utilize the Us Against Alzheimer's registry, which I'm sure many of you all may be familiar with. I would tap into that. It is a very detailed, extensive registry that allows you to kind of identify the CMS process in regards of different clinical settings, areas in which you have a higher population of older age groups, and also potential Alzheimer's organizations. And then the last one I would mention, which you may be familiar with, is research. I'm sorry, I just lost my thought. I can't forget. But anyway, it's not Us Against Research. All of us research, which is an NIH project that looks at collecting data. The goal is to collect over 1 million individuals in research, and it's all of us research, which is actually in various states. Arizona actually has over 62,000 people that have been recruited. And basically what that is, building a database, an existing database. So when research is done, you don't have to do a lot of recruitment. You can get a lot of the information there. So I'm unable to put all of this in chat, and that's why I was just unmuting, but I just wanted to share that.
No, that's wonderful, Angela. Thank you. I know, related to the last point, all of us, is that the National Institute on Aging, they recently put out some very, very large funding announcements, or in the past few months. And one of them is to basically create what is called like real world data cooperatives or something like that. And when I read through it, it sounded a lot to me like creating an All of Us platform, but for dementia. It sounded really familiar. I mean, it sounded very similar to that. And we'll see what that looks like and who gets funded to do it. And it'll be a massive undertaking, but it for the reasons you say, it would be very helpful to have that type of data resource to help drive and assist with recruiting, like Banner does. We've used your registry in our studies, and it's been wonderful.
Oh, great.
Yeah, thank you very much, and we really appreciate it. So
not a problem. I'm the co-chair for the Arizona State of All of Us, and yeah, that is one of the biggest projects, because their goal was to actually reach out to the geriatric population, and they found that dementia was one of the leading causes. Go think, right? So yes. That would be something great. Thank you.
Thank you, Angela, so much. We actually have another hand raised in the audience by Janine Grates. Forgive me, Janine, if I didn't pronounce your last name correctly, but Janine, please.
I was just wanting to connect with Angela because I too work with Sun Health Banner Research Institute from a standpoint. I'm a community business development director for 8 senior living communities in Arizona, and I'm the action chair for Dementia Friends in Glendale. And I bet Angela and I know each other. I'm just not connecting the name without seeing the face. But I've taken copious notes, and one of the things that we want to do in Glendale is start our own registry, because we do have a landing page on the City of Glendale's website. So if you go to City of Glendale, Arizona, and you type in dementia or Dementia Friends, you're going to see all our resources, all of the things that we're doing to connect the public to resources, and then also help reduce the stigma. So I think that we're really grateful. I'm really grateful that here in Arizona, because our population is so densely populated with older adults, the need then is skewed higher for resources, engagement, and data. So maybe this was more of a request for Angela to reach out to me so that we can take all of the wonderful information that we just learned today, because currently we don't receive funding for any of our activities. Everything is volunteer and donation based for our events. So I'd love to work closely with Janice and possibly Angela to expand this to a statewide effort, and just make us more a dementia friendly state.
Okay, thank you, Jeannie. I really appreciate that. Angela, I think Jeannie left in the Q&A box her contact info, so please feel free to follow up with her. Happy to make that connection here today.
Thank you. I will.
Thank you,
I was
Angela.
going to tell her Lori
Yes.
Nixon is the person. Thank you.
Wonderful. Thank you, Angela. So we're coming to the end here of our webinar. Wanted to see if there were any final comments from our panelists here. Any final thoughts before we adjourn? Okay. Well, I think this was a fabulous webinar. We learned so much on what it takes, where we're at with registries in states. And for those of us very interested in advocating for state registries, I know I'm one of them in our home state, what that would entail and what we can learn from, again, these trailblazers. And all of these states definitely are that, I would argue. Thank you for attending. You did receive a evaluation form through Zoom. Please do complete that for us. And again, encourage you to connect with us at the Bold Public Health Center of Excellence on Dementia Caregiving. We do have a website, bolddementiacaregiving.org. As you see here, you'll find today's slides and recording there. And then also, we are always excited to engage with anyone as it relates to dementia caregiving. So thank you for your time. Thank you for the wonderful panelists today. Again, very, very informative and engaging. Hope you had your questions answered. And again, reach out to us if there's anything else we can do. Thanks again, everyone, and have a great rest of your day.